can see is around 5 or 6 degrees of pre-arthritic alignment and about 2 degrees of laxity because it is a lateral side is a little bit lax. This is beneficial for a uni because this will load the uni preferentially. So if you overcorrect it to 2-degree valgus, it will not work. So this patient will become pain-free and he will load the medial compartment. So lateral compartment is protected. You can see the range of motion is getting 126 degrees of flexion. Good patellar tracking, there is no impingement. So you will do very well with a uni. So up to 7 degrees of varus with a fixed bearing uni. In the literature also there have been good results for that. This is not an arthritic knee, it is a sort of a Sonk lesion. Correct. So this is what we were talking about yesterday when we were talking about different alignments. When we were talking about pre-arthritic alignment. So we are restoring this limb to whatever is the pre-arthritic alignment. If you notice, we cut 0 degree varus valgus on the femur, 0 degree varus valgus on the tibia. But still the alignment is 7 degree varus. That indicates it's an extra-articular varus, it's not intra-articular. If I had made 2 degree varus cut on the tibia and femur and then it was showing 4 degree varus alignment, that means I have created that varus.
Okay. That Krishna, can it show us how much?
It is not going actually, that's what. We have resected adequate amount of bone, but with the cement, because we are not able to impact the tibia as we want, that 1 mm is tighter.
Krishna has a question. Yeah. Can you just show us what is the amount of laxity in the extension?
So this is it's almost going to 6 and then it is going to 7 or 8 degrees. So 2 degrees of laxity is there. If I'm stressing it too much, going up to 8.
Okay.
But the native alignment is around 6 degrees.
Okay, 6 to 8, 2 degrees.
And it is 2 degree flexion, 1 degree internal rotation. And as I flex, you can see the varus is reducing. And about 90 degrees, it's becoming into valgus. So we cannot put a poly which is thicker than this because it will take it into further valgus and it will fail. Yeah. Poly set over, cement set. So it's a good idea to keep the knee in around 45 degree flexion and pressed like that for the cement to set.
So what is the recommended laxity for a uni of this in full extension? When you stress it, what is the recommended laxity?
How much lax
it should be?
Normal laxity is 6 to 7 millimeters. That is the normal laxity.
Yeah.
In flexion, about 4 millimeters in extension. But for the purpose of arthroplasty, about 2 millimeters of laxity is what we can accept.
Okay.
Because the limiting factor is the implant and the polyethylene here.
In a fixed bearing.
In a fixed bearing, yeah. But since there is no edge loading and we are able to restore native arthritic alignment, it will function very well, this patient. Yes. Yeah, you can.
Sir, do you anytime release a posterior capsule at the femoral side?
No. I think you should not get it wrong. The surgery is not a soft tissue surgery. It's just a bony surgery. So we will remove amount of bone which will be equivalent to the thickness of implant, and it will resurface the bone. That's all. So there is no soft tissue release which we can perform for a uni. It is just a soft tissue surgery. So it will restore limb to whatever is the pre-arthritic alignment. So in this patient, the Sonk lesion on the medial condyle was painful because the pre-arthritic alignment was in varus. So that is what I told you before. But if we're an arthritic varus, we will correct it 50%. Like if we had a 10 degree deformity, we'll bring it to 5. Because there is bone loss in that. In this, if you notice, there was no bone loss. It was just a cartilage loss in a central femoral area, more like an osteochondral defect or a spontaneous osteonecrosis of the knee. So, but these are the setting of a varus situation.
Yeah, this patient seems to have internal torsional deformity.
Yeah, tibia is in vara.
Yeah. So metaphyseal varus also is there around the 4 degree or so.
Yes, that's right.
Now, if it is a TKR, we will do externally rotate the tibial components. But here, how much rotation you keep in the tibial?
So we again don't temper with the femoral condyle rotation. If you see the patellar tracking, look at the patellar tracking here. So we have not changed anything. This patient did not have patellar maltracking to start with. So you just restore the native, whatever is the rotational alignment between the femur and tibia. And if you see here, can you zoom in here? Look at how it is articulating. So this is an extension. The femur and tibia are in the center of each other. Take a line back there. The main problem with a fixed bearing uni is a other side. Is a edge loading. You can see here how nicely the femur and tibia are loading reciprocally. It's exactly in the center. So there is no edge loading at all. So this is advantage of using technology because it is predicting where it is going to load. Of course, you can do it with surgery, but if you make an error, there is no bailout. You cannot come out of that situation. But since we have made this the rotation, everything based on native rotations, whatever the patient had, the articulation will work and the patella will track well. Yeah.
So for my knowledge sake, suppose if you are doing TKR in this case, so
Yeah.
you will be correcting the part of the varus on the tibia?
Yeah, that is your call. So, in these cases, what we have tended to do was, we have tended to accept about 4 degrees of overall varus alignment. It washed 3-4 degrees. So I'll correct it partially. I will not correct it fully.
Thank you.
इसका ये थोड़ा
And how much FFD will you do a uni?
up to 10-15 degrees we can
Correct. Then you will.
no, don't flex that much. Everybody should not do, man.
At that time, you will remove the osteophytes or
Right.
if there is an FFD.
You can, it depends on the way it is. If it is because of posterior osteophytes and all, it will get corrected. And usually the flexion deformity is because of anvil osteophyte, one osteophyte in the intercondylar notch, which will cause that loss of extension because it will impinge in the intercondylar notch. So you remove that, it will go, and little bit posterior osteophytes you can work and then get it corrected. So this looks very good actually. You can see there is not much laxity, and this tracking is very good. And the femur is translating back. That means there is some rollback which is happening on the femur because of the PCL function. And you can see that the patella is tracking fantastically well. And you can see the ACL still intact. You can see with a nice bridge of bone there, which we protected throughout the surgical intervention.
Correctable deformity in both planes, sagittal and coronal. 10 degree FFT, 10 degree, it should be correctable deformity after anesthesia. So I think.
That is true, but at extremes of age, you will err on the side of uni, even if it is not a very ideal indication. Because if it bails him out for 10 years, this will be a revision to a primary TKR. But if you do any other TKR, you will have to do a major revision.
What is the youngest age you have done, Dr. Preethi?
So my youngest patient was 41 and he is 14 years out now after Oxford Uni, and he is still doing well. So uni is a surgery, if you do regularly, then you get to used to it and then you understand, oh, it functions extremely well. Patients are very happy. I think Ashok will vouch for that. They can have no restrictions. They'll sit on the floor, squat, do everything. And it's a phenomenal operation for the patient, injection.
So anywhere bone on bone arthritis, bone is touching each other.
And you see the incision. You see the incision for the uni, it is like so small. So naturally the recovery is much quicker. So these patients, you have to tell them not to be very active. You have to tell them, please don't be too active for about 6 weeks or so. Otherwise they will come back with hemarthrosis and all these sort of things. So now you can see here, this is the VMO and I'm injecting under the VMO. And this will contain that entire anesthetic and it will keep on eluding in the post-operative period. So the patient will have lesser pain. And as the unit is giving the adductor canal block, so they can be mobilized on day 1. And you can see here, this is a meniscal remnant and the joint line is exactly restored to the meniscal remnant. So there is no joint line elevation also in this case. Suture?
Dr. Kiran, is if a 75-year-old man medial cumbal arthritis with some petrofemoral, with good ACL. The good ACL means some fibers are split. Do you still do uni?
I would definitely offer a uni. Problem nowadays is patients make the selection. So I will offer any patient who is on the extremes of age. Yeah, please. Who's the extremes of age to get a UKR done.
Thank you, Dr. Kiran.
Yeah.
Fantastic surgery, wonderful demonstration in the morning.
Excellent surgery.
Thank you very much. How do you like it?
Thank you, sir. Thank you, sir. After this wonderful demonstration on UKE, we move on to the next topic of discussion on technical aspects of UKE, Unini arthroplasty. Now, we welcome our moderators, Dr. Bharat Kumar sir, Ishwara Hospitals, Madurai, and Dr. Pavalan sir with HOD from Thuthukudi Medical College on the stage, please.
Good morning, everyone. In the Unini session, we are moving on to the lecture aspect on technical aspects of Unini. The first topic will be by Dr. Dikshit Chandrasekhar on indications and implant choices in Unini.
Good morning, everybody. I thank you all for giving me opportunities to deliver my talk over here. There was excellent demonstration of how a unique condylar arthroplasty should be performed and what was their indication. It was a nicely indicated patient. Let's see and just revise it up what we have seen in the morning. So, national joint registries from UK, US, Australia, they are going to predict, they have predicted that the revision rate probably in 2030 to 2040 will be 600 times what we are doing today. And that's why we need to offer a proper surgery for a properly indicated patient so that our revision rate should go down. So coming to history, there are the Helbach who has demonstrated in his study that 85% of their patient had only medial compartmental OA. The first UK was performed in 1954 by Mackintosh and Hunter, and historically it has given a good result, good to excellent type of result. But it contributes to only 5 to 6% of total arthroplasties which are being done for the knee. And the TK, which we know of that 18 to 20% of the patients which are still unhappy are performed over 85 to 90% of arthroplasties of the knee joint. So as we know, what are the advantages of UK over DK? That is a less invasive procedure. We saw that it was performed in a very small incision. It preserves a lot of bone. It preserves ligaments. It preserves even ACL. It is having less complications. Lastly, we saw that the patient was offered very less restriction of the movement. So it is easier to and if it required to revise, it is easier to revise the UK than revise the total knee arthroplasty. What are the disadvantages of UK? It is a specialized procedure. We need a lot of procedures to be done to get and acquire the skills to have that procedure. And it has been shown that it requires a higher revision rate. We will come to know that. We'll come to that point. And the only proper possibility is that the progression of OA can still happen even after performing OA UK because there is still a lateral compartment and petrofemoral compartment which is still intact. So why it is less popular after initial good results, that it is proposed that it requires a high revision. It is having a long learning curve. It takes n number of cases, say more than 50 to 60 number of cases to acquire a good skill to perform UK. A lot of things depends on the implant positioning. How do we position our implant? The rotation of femoral component, slope of tibial component. A lot of things are dependent on that. That's why they tolerate very less error, and the progression of osteoarthritis and ligament injuries is still a possibility of UK. So it is feared that I might require to revise my UK or somebody else will revise UK. That's why the UK was less popular. But with the same paper, Dr. Hemant Pandit and Felix Dodd showed that if the if the patients are selected with proper indication, and if we perform more number of UK over a period of time, the revision rate goes down. So think of UK as a first surgery to the patient when he comes to you for for anteromedial OA, and more the number of cases we do, the less will be the revision rate of thing. Goodfellow has coined the term called as anteromedial OA. This is the indication for UK to be performed. What is anteromedial OA? Is only anterior part of tibia and weight bearing part of femur is involved in osteoarthritic changes. The lateral compartment and probably patellofemoral compartment is normal. So in their typical paper, they have shown that they have photocopied the tibia, and they said that it is only the anterior and middle part of the tibia is involved when there is intact ACL, and when the ACL ruptures, more posterior part of the medial tibial condyle starts getting involved in osteoarthritic changes. So the pathoanatomy of anteromedial, there is the anteromedial changes in extension. If your ACL remains intact, there is a femoral rollback which occurs along with PCL, and that keeps the MCL intact or taut. That's why it is a correctable varus in anteromedial OA, because your MCL is not shortened. And if the disease progresses, in that progression of the disease, ACL gets ruptured, and that posterior rollback which doesn't happen gives posteromedial degeneration, and patient goes into fixed varus with tight medial collateral ligament, and the disease progresses to the lateral compartment. And it is this stage where we can halt the progression of disease by performing a proper UKA. This is the depiction of what happens in anteromedial OA, and the posterior condyle and posterior middle part is intact. Because of that rollback which occurs, medial collateral ligament remains taut. So the patient selection for UK is the key. In this classic paper that Cosin and Scott has put forth their indication, they limited UK for the very limited subset of the patient, in which the patient should be around or more than 60 years. His or her weight should be less than around 80 kgs. Varus should not be more than 50 degrees, and it should be correctable or fully correctable. The stress of the fully correctable varus. FFD should not be more than 5 degrees, and patient should have at least 90 degrees of range of motion, and patient should not indulge into the high activity or high performance activity. And they contraindicated the patient who had high activity levels, chondrocalcinosis, gout or any inflammatory arthritis, osteophytes in other compartment, the lateral compartment and probably a patellofemoral compartment, and clinically deficient ACL. But when Dr. Pandit and Oxford group reviewed their 1,000 cases, they found that they got 68% of patients were not fitting into the Cosin and Scott indicated patients. And they found that the patients who were having high BMI also had a good outcome. most of their patients, say 70% of their patient was having a clinical ACL laxity which was grade 1 to grade 2. Even those patients did well. And it came out through the group of mobile bearing Oxford unicondylar arthroplasty. Few of their patients had patellofemoral involvement also. And same was put forth in consensus group of JSOA 2015 that a patient with patellofemoral arthritis is not a contraindication if it is only a medial facet of patella is involved. ACL deficiency is not a contraindication, and a patient with high BMI can also go ahead with, we can also go ahead with UK for high BMI patients. So age right now is not a contraindication, as we listened to Dr. Krishna Kiran that his earliest age was 41. My eldest patient is 82. There is no limitation of activity level. There are good results which are shown in the recent studies that even high BMI patient can go ahead with UK. And the only contraindication right now is a kissing lesion or involvement of lateral facet of patella. Presence of lateral osteophyte on X-ray is again not a contraindication. What is more important is to have a preserved joint space on the lateral compartment when we do a stress X-rays. So what X-rays we want to do? We usually do a standing or weight bearing X-rays, AP and lateral. And lateral, we should give importance that there is anteromedial OA or only anterior part of medial tibial condyle is involved. And we do a scanogram to assess the varus, to quantify the varus, and most important X-ray to understand whether patient should go for your unicondylar arthritis or not is the varus stress X-ray, which shows there is opening of the medial joint space. But we should also look forward that there is no decreased height or decreased space on the lateral compartment. It means that the lateral condyle or lateral compartment is intact, the cartilage is intact. So offer the patient, offer a UK if you get a patient around 60s who is having anteromedial osteoarthritis, functionally stable ACL with correctable varus around 10 to 15 degrees, and patient around 10 to 10 degrees of FFT can go ahead with UK. Now the question arises, are you confident enough that your ACL is intact? So shall we do your MRI pre-operatively or not? So the literature says that MRI can be inconclusive. It may estimate that your ACL is intact. So we need to rely on our clinical judgment that whether ACL laxity is there or not. So coming to implants, there are basically two types of implants which are available in the market. One is fixed bearing UK, which we saw in the morning. The Smith & Nephew Journey Uni is a fixed bearing implant, and the Oxford, the mobile bearing implant, which is I know of, which is only available with Zimmer Biomet, which is an Oxford Uni. They are fundamentally different. The poly in fixed bearing implant is fixed to the tibial base plate, and the poly in mobile bearing implant is mobile. It is not fixed to either femoral component, not to the tibial component. So it moves in a femoral and poly surface, and there is a movement at poly and tibial base plate also. So the mobile bearing unit, the mobile bearing implants, they depend on the stability of implant itself. They offer more conforming surfaces to femur and tibia and works on stability principle. It has been shown that a patient undergone with mobile bearing unit has more kinematic movements of the knee. The only possibility of dislocation is because of bearing dislocation, because it is too much mobile. Too much mobile in early phase when patients get rid of their pain. The mobile bearing implant has a long learning curve. The implant positioning is the most important part in this procedure. So it should have a less error to have a more longevity. And because it needs a lot of skill to understand to do this procedure, it has to be done by a probably skillful surgeon who is having high volume. As against fixed bearing implant, the surface are less conformable. That depends on the ligament stability, and we can accept around 2 degrees of laxity after performing this procedure. The main way of failure of this is polywear and progression of osteoporosis in other compartment. So it is preferred by a low volume surgeon, which we will say it allows some error to happen in our procedure itself. So it is a mostly a kinematic alignment principle. It works on the kinematic principle. We do not correct varus fully. We either partially correct or do not correct what we saw in the morning. And it is like a true resurfacing of the implant, of the medial compartment. And it is more important to have anatomical position of implant as possible. So robotics, what we saw in the morning, helps in position of the implant and gives a proper alignment. It helps into real-time change the position of the implant and gives good balancing, a documented evidence of balancing. So the robotic definitely helps us to perform this surgery in a better fashion. So to take home message, consider UK as a first line of treatment. Correct identification of the individual is more important. Increase number of cases actually decreases the failure rate. Consider fixed bearing implant design in early stage of our unicornal arthroplasties, and use of robotic actually decreases the unforced errors, and it acts as an intelligent assistant for us to have a successful TKR. Thank you.
Discussion is now. Go to Dr. Rajkumar from Ganga Hospital on Udemy past, present, and the future.
Okay. Good morning to all, and once again I'd like to thank Dr. Professor Shokma sir and his team for this excellent meeting. Coming to the topic, thanks Bharat. Coming to the topic, the past, present and future, I would like to the previous speaker has covered the entire spectrum of uni, how to select, what to do, and what is the correct implant. So I will just try to put it in nutshell, and I thought not many will be knowing about the past, so I added few more slides for the past actually. So to start with, in 1950, around 1950 to 1960, it started as an interpositional arthroplasty. It was not a pure uni, so it started as an interpositional arthroplasty, but it was abandoned, and then it came the bicondylar with two pigs in both the condyles, that is the medial and lateral. So that Gunston developed in 1968. So it has underwent. Then in late 70s, they started this modular UKA, almost like a conservative approach and resembling to a total knee, but it is not a total knee. People started doing that, and many modifications happened. It is comprised of a biconvex metal sheet. So that is how it started. Then in 1980s, the modular UKA started to come in, but increased wear and the loosening due to various reasons, this was abandoned. A lot of failures started happening, so people really put into a lot of research into the development of design. That was one, and that design change happened, and then the fixed bearing came in. So in fact, it was the fixed bearing which came in before the mobile bearing. So in 80s, the fixed bearing came in, and John Goodfellow and John O'Connor developed this mobile bearing. And as the previous speaker said, at present this is the only mobile bearing available. Rest all fixed bearing knee replacements. So when it comes to the mobile bearing, So the principle is very, very simple and straightforward, which applies to almost even to the fixed bearing also. So the mobile bearing, what is that principle? Distracting, sliding, rolling movements between the bones without restriction. That is the point number one. It has to be there. All soft tissue should be kept and preserved without doing much damage to the soft tissue, ligaments and muscles. So put the implant, don't do anything to the soft tissue. The area of contact should be better. More the contact, the better. So that is the principle in a mobile bearing. So this is what they developed. This is the past. So keeping this in mind, and in fact they are following that. And to put it in a nutshell, this is the timeline of events which has happened starting from 54 to 82. From that time, it has become a reasonably standard fixed design. So in the past, Oxford underwent a lot of changes in the instrumentation, phase 1, phase 2, phase 3, and now what we are using is the microplasty instrumentation. Quite good, results are very good. So the present one, now we are going into the present. The present instrumentation is very good with the mobile bearing. It has got a very good outcome, improved patient satisfaction and component positioning. So the criteria already has been discussed. I am not going to go in detail. With this criteria, the results are good. That is in present. Now we are talking about present. With this criteria we follow. So what is this criteria? Again discussed previously. I don't want to waste time. We have to be very clear. Selection has to be very clear. Indicated, non-indicated. So the present, the results are very good. That's what a lot of literature says about the mobile bearing. Very good results, Oxford, good survival, patient satisfaction, all those things. If you go into the literature, you have enough evidence to say that yes, it is good patient satisfaction. But you have to also be very clear what is happening in the registry. That gives you a very good data. In 2023, recently published, the numbers happened in this annual report is 75,719. This is NHS data. Overall, the performed number between 2003 to 2015. Fixed bearing is 31.3%, mobile bearing 67%, average patient age is 64, but the survival rate, it is not as comparable to TKR. It is lower than those of total knee replacement. 5-year survival is 97. And even the Finnish joint registry says, this is present I am talking, the Finnish joint registry also says UKA, the results are inferior when compared to TKA. This we have to keep it in mind. So in present, with these kind of X-rays, we all know, no doubt about it, we need to do total knee replacement. That is, everybody knows that. But the problem comes when you see these kind of X-rays, medial compartment OA, anteromedial, wherever it is, moderate arthritis, what to do? Big challenge, these set of patients. This we see in all age group. Patient complains with a lot of pain, so we have a lot of challenges. They come to the clinic, always keep complaining of severe pain. So unicompartmental whether to do always generates a lot of debate. So what to do? We have a big doubt whether to go for TKR, uni or a HTO. This is a never-ending debate in any meetings. This is what we have to do. But if you look at the literature, very good survival rate, 93% at 10 years and 90% at 15 years, but see that older than 75 years. That is the most important thing. If you want to take it very, very clearly from this talk, is that more than 75 years, like that is old age group, the results are very good. 93% and 90% at 15 years, that's a good result. On the contrary, 2020 published, revision rate higher in UKA, but what is the problem? Age group. So these survivals, revision rates, failures are all happening in the younger age group. So high revision rate and failure in UKA, why? It is often associated with indications that are not strictly correct and also the surgical errors. So these are the two things which causes the failure in UKA. This patient, 40-year-old male, you can see that patient has already underwent arthroscopy procedure complaining of pain. He is only 40 years, this pain. The surgeon has done an ETO. Okay, this patient already having both the compartments are there, arthritis is there, but surgeon has done an ETO, H2O, sorry about that. So he has done an H2O for this, 40 years. 1 year later, patient develops pain in both the knees. So what will you do? So here, right side we know it is already, all the compartments are involved, it needs an implant removal and a total knee replacement. But the surgeon did a bilateral uni, both sides. So medial side, right side, he has done a uni. So what happened? Insert spin out. That was a mobile bearing. Insert spin out has happened on the left side. So now what to do? Again, patient is having only 41 years. Now what to do? You know what the surgeon has done? Surgeon went in, did the MCL reefing on the left side with bigger poly insert. So here everything is there. Younger age group, wrong selection of patient, wrong selection of surgery, and again things are getting complicated by improper decision making. So that is what the problem comes in. 56-year-old female, patient has got pain on the right side, underwent an arthroscopic chondroplasty and microfracturing medial femoral condyle of the right knee. So these are the things the patient has underwent for this right knee pain with this X-ray. And then 2 years later, same surgeon has done a UKA right side. So for that patient, again patient is only 56 years old. Now patient is having severe pain in the right knee. You can see that in this age group, 40, 50 and all, the patient selection is very important, indication is very important. So if you look at the Australian Joint Registry, the lesser age group, more chances of failure in UK. So we have to be very careful. We maybe few surgeons who are really experienced enough, maybe their results may be good, but overall, this is a very important joint registry which gives enough good data, says that more chances of failure in UKA if the age group is very less. So avoid doing UKA in younger age group unless otherwise it is indicated correctly. So what is that in present? Present, you have enough good implants like in a total knee. So if any time a doubt, please do not venture into UK just for the sake of doing it. 66-year-old female, left knee pain. If you look at that, the lateral compartment looks near normal, but it is not. It has got ulcers on both sides and the patellofemoral joint medial facet is involved. Underwent a left total knee replacement, patient is doing well. Again, right knee pain, 71 years old. Just because old age we can do a total unicompartmental, we should not jump in and do that. Look at this case. Again, a bone on the medial side, patellofemoral, no arthritis. Whether to do a uni, look at this peroperative finding. Lateral side is also, lateral femoral condyle is involved. Medial femoral condyle is involved. So, be careful, select the right case. This patient, I did a cruciate retaining total knee replacement. Patient is doing well in the immediate post-operative period. So look at the joint registry which says age group 55, less than 55 years and all, uni is happening in a big numbers. So we have to be very careful. When compared to in the registry, the fixed bearing is going up, the mobile bearing is coming down. This always keeps fluctuating but now the difference is big nowadays. So fixed bearings are happening more. Coming to the present, again, robotic assisted, it is slowly picking up. Non-robotic assisted is coming down. Robotic assisted, TKA, low risk for revision. So current data says technology assisted UKA is got low revision rate. So one of our, Dr. Narendra Vaidya has published that long-term follow-up of patients' functional and radiological outcomes are good with technology assisted. So what is going to be the future now? Now we are going to talk about future, just few slides more. Future is going to be that more and more design changes are going to come, lateral compartment, patellofemoral compartment, all those things are going to happen, that is for sure. But we have to be very clear in selection and the technique and the technology. So robotic assisted UKA definitely gives good results. That's what the literature says. Recently published everything 2021. You can reduce the number of outliers concerning the optimal implant positioning. Because Kanduja has in 2019 Journal of Knee Surgery unicompartmental, the past and the future perspective. So we have concluded, despite being initially disregarded, UK is in the middle of Renaissance. So we are in the middle now. We have developed a good design. Definitely there is good implant. We are technically we are evolving. We are having a lot of good courses to teach the youngsters. There is a lot of plethora of exciting future directions to pursue. But the ultimate goal should be improved longevity and optimal function. But however, remember that patient selection and the surgical technique will always be gold standard, whether it is past, present or future. To summarize, past we were having primitive processes, present improved processes and techniques with wide indication. So we have to be very, very clear that indication has to be very strict. Future will be patient selection and technology. Thank you.
Thank you, sir.
Thank you.
Yeah, I have a question here. Rajkumar,
Yeah.
nicely you summarize past, present and future. It can be for everybody question. I've seen some x-rays. Some people have put interposition discs, metal discs. Do you have any experience? Anybody can tell me. I've seen a couple of x-rays. Patient
In the present?
Patient done 10 years back.
10 years back.
Anybody has seen?
No.
Metal disc there, I think they're taking out the meniscus. It's like interposition orthoplasty. And one of the surgeons in Bangalore has done few hundreds.
Oh, you?
Yes. So that is one question. Do anybody have the experience in your states?
I have not seen.
Second, for future, now that Epicure has come.
I actually that slide was there, but I removed want of time. I know that Epicure is basically doing an MRI of the knee joint, and once that MRI is done, based on that MRI, custom-made implant, not for the entire compartment, only where the ulcer is there.
Yes, cartilage lesion is there.
And then you put cement and then like a plug, you keep it as a metal, like an
What we
interposition.
do in arthroscopic boards, same thing wherever a cartilage lesion is there, you have to drill hole and they will give a customized implant, you have to fix it. It's not articulating, that means both sides implants are not there. Wherever the lesion is there, only cartilage and metal is covered.
Yeah, it is in Europe they are doing. We have to do the MRI here, send the pictures to Europe,
Yes.
and within 7 days they will send you the implant. I had the slides, but I removed for want of time.
Maybe that's the future.
Maybe, yes. Lot of things will happen, but at the end, as I told, we have to be very, very strict in the patient selection. So many examples like that, what I showed like that.
It's a basic combination of the 3D printing. Yes. Basically, 3D printing being incorporated into orthopedic surgery. We have this going on for a long time in talus replacements. When we see that the talus is missing from the site after injury, we usually take the CT scan of the opposite talus, send it to a 3D printer, get a accurate size talus and then replace it. We are seeing such cases. I think they are being followed up in Rajasthan, some center in Rajasthan. In large numbers, they are doing it. And I think this is the future, that we are going to use 3D printing a lot in orthopedic surgery to exactly get the exact size of implant that we need to customize for each patient.
Thank you.
Rajkumar, is it the same surgeon who did all the 4 surgeries for that one patient?
No. Two cases, two different surgeries.
Because I just wanted to know where in this part of the world you have such tolerant patients.
You want to know that there?
Yeah.
You will get shocked.
Thank you, Rajkumar. After you have shown alarming X-rays, first we thought we can go for TKA, unicondylar for many cases. After seeing these case studies, we must be very careful. Okay, now there is a change in program. Now I call upon Dr. Mukesh Mohan. There is a change in order. Complication bailout options in UK.
So I before he loads, that because I actually wanted to add one more slide. Our part of the world, the patient's bone morphology is totally different when compared to Caucasians, Western population. All the studies, see, most of the studies are from the Western population. Their size is totally different. All the design has been for them. Our knee is not for that size. So we have to be very careful. We deal with a lot of inflammatory conditions. So, patients.
One additional point regarding microplasty, what way is going to be on the slide.
Actually speaking, there is no clear evidence, structured evidence to say microplasty will work. It is only the mind game. So, with mental satisfaction, people are doing it.
Good morning, everyone. And thank you, Professor Kumar sir and the Preethi team for giving me this opportunity. And thank you, Chairperson. I'm going to talk on complications of UKA, how to prevent it, and bailout options. So when you want to do a successful UKR, as everybody was pointing out, we have to choose the right patient, right indication, and pre-op counseling is very important because like we may expect to progress it to a lateral compartment disease also, and we may have to pre-operatively counsel the patient that intraoperatively you may have to change it to a total knee replacement to in case of any change in the plan or any change in your intraoperative findings. But many literature studies shows that 45% of our posted TKR patients are actually an ideal candidate for UKA. And we have to confirm that it is only an anteromedial osteoarthritis. When you go by the ideal indications, patients are ideally should have a low activity, BMI less than 82 kg, and clinically they should have a pointing sign of pointing towards your anteromedial compartment. Should be a correctable varus less than 15 degree varus and less than 10 degrees of fixed flexion deformity. Then where all the pitfalls can occur. Either it could be an error of judgment, or it could be a host factor, could be a surgeon technical factors, or it could be implant-driven complication factors, or technology-driven complication factors. Broadly, we can classify these things into various headings. And errors of judgment, as I was telling earlier, you have to confirm the indication. Intact ACL, anatomically and functionally should be confirmed and should be an isolated anteromedial osteoarthritis with sparing of both patellofemoral and lateral compartment. However, the recent guideline shows that minimal fibrillation over the trochlea is not a strict contraindication for a uni. And for a marginal ulcers in lateral femoral condyle, along the margins of the condyle, not in the central part. Still, it's not a contraindication, and lateral femoral osteophyte is definitely not a contraindication for doing a uni. So, once opening up, you have to confirm these indications by testing the ACL both anatomically and functionally. Having confirmed that, then the other factors, the host factors. Again, you have to be very careful in choosing a patient who is a morbidly obese patient and diabetic patients with neuropathy, because many of these patients, even after do a successful UKR, if there is neuropathy is present, the patient have an unexplained medial knee pain, which cannot be explained by any factors. And the patients may come with polyarthralgia. Sometimes they may have a classical indication of anteromedial OA, but of late, when you follow up later, they may progress to a full-blown rheumatoid arthritis also. So these patients we have to be very careful. So you have to doubly confirm that you are selecting a patient who is not an inflammatory arthritic patient and patient with severe osteoporosis, because the only dreadful complications is tibial condyle fractures. This is very high in severe osteoporosis, and patients who have a history of somatization disorders. Okay? Even if you do a perfect TKR, the patient may not feel happy, and he may not feel happy. So what are the manual or even robotics technical errors can happen? One thing is over-release of medial soft tissue release. This may lead on to a overcorrection, then future progression to lateral compartment osteoarthritis. And when you do a cutting error, you can make a tibial cut either in varus or valgus, and if you have to identify the intercondylar arch. If you make it too lateral, there is a chance of injuring your ACL, but if you make it too medial, then you will have to undersize your tibia. Then your overhang may occur. The medial edge of your component may overhang over the medial tibial condyle. So you have to correctly size it. And if you are a manual uni, then when you use this reciprocating saw to cut the sagittal cut, and if you angulate your hand posteriorly, then you are liable to cut the posterior cortex too deep than your anterior cortex. Then this is an inherent risk factor for a tibial condyle fracture. So you have reciprocating shaft should be exactly parallel to the tibial plateau. The hand should not get lifted up. And if you are using a mobile bearing uni, then you have to understand the spigot numbers. Like if you mismatch your spigot numbers, then you may over resect your femoral condyle. And regarding the placement of the femoral component, there are errors in both placement in varus and valgus sides. In mobile bearing, you can have a play of around 10 degrees, but for fixed bearing, don't go for more than 2 to 3 degrees. And placing the component medial laterally is very important to avoid edge loading. So what are the factors associated with the implant design? Especially, sorry for that. And the mobile bearing unit which is available in India, many times because of the small stature of our patients, the tibial size is too big for our female patient. This can lead on to an unexplained medial pain. And as explained earlier, there is a chance of spin out and dislocation. And the older designs like single peg design, they had a very huge rate of early failure. Now they are modified to twin peg design. Regarding the fixed bearing, if it is not positioned properly, edge loading is going to occur, and you should not make it too tight. You should have at least 1 or 2 millimeter laxity throughout the range of motion to have a good functioning fixed bearing unit. Again, when we use robotics, the pins we use is usually we keep it away from the field. In TKA, we can place it very closely, but in UKA, sometimes we may have to place it away from the field, preferably maybe in the diaphyseal region. That is a chance where you may get a stress fracture. Now I currently use the mediolaterally directed pins in the femoral side and a little away from the proximal metaphysis of the tibia, so that, and I use only unicortical pins with just kissing at the second cortex. We should not do a bicortical pins. This is an example of indicated anteromedial OA patient for which we have done a femoral planning. This is the mapping of the femur and tibia, and you can adjust your femoral component position. Usually we match the posterior condyle of the femoral component along the posterior cortex of your femur, and you can adjust it 1 or 2 millimeter to loosen up the flexion space. And this is the preoperative planned graph where you have a uniformly balanced graph. So when you plan, you position the posterior edge of the component, and also when you plan the tibia here, so either you do manual or robotics, you make a plan so that the lateral wall of your tibial component is at the midpoint of your medial tibial spine. So the cut has to be along the midpoint of your medial tibial spine, so that you will have a wide coverage available for our tibial plateau, so that you can avoid a undersized tibia. Also, if you make it too lateral, then you may injure your ACL. So, and once you, this graph shows that the deeper flexion gap is tighter and extension it is well balanced. So we have to anteriorize the femur so that you loosen up the flexion gap, so that the graph moves up and you get a well balanced graph like this. So once you finalize the plan, then you use your robotic work to mill off your distal femur. And then when I do the tibial preparation, even in manual as well as in robotics, I take the intercondylar cut first, so that I remove the lateral wall first. Then I can remove the medial part very easily. So this is how we implant it, but never use a bigger mallet. Now you could have seen that I am using a smaller mallet. See, this is the cause for fractures. You have to use a smaller mallet to impact. If you use a bigger mallet, the force is too heavy, then you may have an intraoperative fracture. And when you question the femoral component, make a very thin layer of cement and make sure that you remove all the posterior cement and insert. This is a fixed bearing unit. And throughout the range of motion, you should have 1 or 2 millimeter laxity. So this seems to be a well balanced. So this is the post-operative graph showing a well balanced 1 or 2 millimeter laxity throughout your range of motion. And the pre-operative alignment is around, planned is 4 and we got is around 4 degrees. And this is another patient with severe varus, and we have planned alignment of around 0 degree, which we were able to achieve. And this is a 75-year-old female who had a bilateral single stage uni, and this is the post-operative 14th day, and he is able to have a very good function. So the advantages of doing uni in an elderly patient is this early recovery. This is the only point that we want to stress upon this. And sometimes in an ideally indicated patient for less than 60 years, these patients have a very good range of motion. Again, a bilateral, one side TKR, another side partial knee, having very good function at the end of a month on both right side and left side. Okay. So coming to the complications, touch wood, I didn't have any complications, but if I say that I don't have much complications, either my patients would have lost me and maybe they would have ended up with Rajkumar to go all the surgeries. Or sometimes the patients, these things I got it from net and from one of my friends. This is a tibial condyle fractures which was missed intraoperatively, and the patient was mobilized and subsequently it is getting displayed. Again, what I was explaining to you is the force which they use and the deeper cut at the posterior tibial cortex. If there is a tibial cut there, then it is likely to get displayed on when the patient ask the patient to mobilize, and which was treated with a compression screw fixation. Again, this is a early failure, and which was revised by a primary total knee replacement. Again, this is another tibial condyle fracture, which is revised with thing. And this is a medial condyle fracture, mixed elsewhere with the plating. Again, I am going to show the same set of X-rays which were shown by Rajkumar. This is a conservatively treated patient. This is the same patient which you have shown. Bilateral unit done elsewhere. This patient had a spin out and they have done an MCL reefing. And also, like when you look at this, there is a valgus alignment, then this is going to have lateral condylar progression also. So these things we have to avoid. See, this is going to give bad name to this procedure itself. So to summarize, we have to plan our steps well, and uni should be considered as an artistic surgery where precise sculpting is needed, and we should have a gentle hands with lighter instruments to prevent fractures, and also we should be beware of operating in areas of non-believers, because like whatever the patient may express, then this other surgeons is going to comment a lot about uni. So this is the difficulty of uni surgeons. Thank you all for your patience here.
Can we proceed to discussion? The other talk, the surgeon is busy in the OT.
Question to Raj Kumar. There's a recent paper by Pandit stating that in patients above 70, elderly, even if there is an ACL deficiency, you can still go ahead with the partial knee replacement surgery because the stability is already given by the surrounding fibrotic capsular contractures.
Before answering that question, if you ask the Oxford group or the mobile bearing team, particularly all the designers, over the period of time I've seen, in the last 15 years, I've seen them, every time you go and ask one indication to them, can we do this, can we do this? I have never heard any time they telling, no. They always say, please do it, document it, let us discuss, let us see. So that means what? They want to see that implant, how it is performing in every single indication which you are having a doubt. So that is where the patellar, whether lateral facet to do or not, whether the medial facet, whether ACL, whether the lateral compartment osteophytes are there, whether to do or not. So like that it keeps extending. So whether to do for a ACL deficient knee in a 75-year-old patient, I will say personally, I will not do. Why to do an ACL deficient knee, that do a this thing, mobile bearing, and then have a doubt, whether it will perform or not, whether it will survive or not. No. For that level, you can give one procedure for that patient, a total knee replacement. So that should be the thing. Literature-wise, that might have one small set of patients might be doing well, but better to avoid.
Any other questions from the floor?
Now, as Dr. Mukesh says, you have to believe the surgery before you start doing it. And Dr. Rajkumar clearly said, Oxford group has no contraindication. There is no contraindication for the surgery. He says in every condition you can do unicompartmental knee replacement. In those, most of the cases which we think should go for local knee, they will opt for unicompartment. Really difficult to accept their indication and do in our setup. It's really very difficult. And Dr. Rajkumar says in the elderly patient, when you have tri-compartmental arthritis, a borderline indication, I still am doing a total knee replacement, give a good results than having a mobile bearing uni and facing a complication later.
In fact, I will suggest the condition which you said, ACL deficient 75, do a cruciate retaining. A well done cruciate retaining, patient will be so happy. So that is very good.
Okay. When you are taking a tibial biscuit cut, have you ever had the chance of cutting the deep part of the MCL accidentally?
Unfortunately.
Because the whole surgery revolves around preserving the deep MCL, which normally the TKR surgeons are normally not aware of actually.
Okay. Unfortunately, I didn't, probably I might not have realized that, but unfortunately I didn't feel that. Right? And I didn't have a chance to changing my plan to, because of MCL injury, changing my plan to UKR to TKR. So, we didn't have that. So, but only thing what some of my patients have is unexplained needle pain whenever I do Oxford uni. Two of my patients had persistent pain. But even though radiologically everything good, well, and was light under correction only, but still unexplained pain.
Maybe the poly would have spinned 180 degrees, 90 degrees. No.
It was very good. Because like we can see it in the post-operative X-rays.
Yeah, I had one such patient who had a spin of 90 degrees.
Okay.
And I had to manually push it back into position and shape it down.
But that markers, radiological markers were intact.
Okay. Thank you, Mukesh. So after the next session, we know.
Thank you, sir. Thank you, Chairperson. Now we move on to our inauguration ceremony.
morning. We welcome our chairman, Professor Dr. Shivakumar sir, Managing Director Dr. Hema Shivakumar ma'am, Professor Dr.
Post-operative yesterday's live surgery is displayed.
So this is the first case we have done yesterday.